you've done some significant work which shows that fewer people were treated from the waiting list since the elective recovery plan was published in 2022. Tell me more.
So I guess the purpose of the report is that there's a growing consensus that the problem in our economy is perhaps not completely unrelated to the problem in the NHS. We have one of the forecasts to be the slowest growing economy in the rich world. Got lots of people that are missing from the labour market, a reasonable proportion of those because they're sick or unwell. So we asked, OK, well, there's 7 million people waiting for treatment in the NHS, non-urgent treatment, anything from a cataract operation to a knee replacement and all the bits in between. If we manage to treat those people, is there a benefit to the economy? What does that look like? And we estimate that at £73 billion over 5 years. And that's just delivering against the trajectory the government and the NHS England have put up. The big problem here is that we're quite far off that trajectory. We're 1 year into this 3-year plan, and we wanted to go up from sort of the year before the pandemic, 30% up. We've actually gone slightly backwards. And so what we're trying to say in this report is actually it's very important we deliver against this plan for quite basic reasons. In general, sort of, we don't want to live in a country where people are suffering avoidable pain or suffering with an illness that we could treat if they just had access to timely healthcare. But there's also a strong economic case here to really get through this backlog of care.
Fabulous. How do we do it?
So there's a long answer and a short answer.
Let's go with the short one. OK,
the short one is, the NHS we need to work out what kind of NHS we want, right? We've got what kind of NHS we want, what kind of resources and
You already spent
reforms.
a fortune on the NHS.
Right, so there's a transformation project to pull the NHS into the 21st century. We still run it as if it was an illness service back in the 40s and 50s. We need to transform that, but that's a 5 or 10 year project, Kay. What we're doing here is actually, well, what about the 7 million people waiting today? Like, we can't ask them to wait 5 or 10 years for us to transform the NHS and whatever we think it needs to be. So there are things we can do today, right now.
Go on.
And a lot of that is about improving the pathway for patients. So all the way from when a referral is made, you need a knee replacement. At that point, for example.
Steady on.
Well, sorry, I wasn't talking to you, Kay, but in hypothetically speaking...
You young people.
I might need a knee replacement too. But we make that referral to one hospital. We say, OK, well, let's send you to one particular orthopaedic department. That doesn't make very much sense. If there's a quicker option that comes up, let's say 10 minutes away, you can't actually access that because you've been referred to a very particular hospital. We're saying, OK, well, within a geographical region, why don't we pool those lists? So whenever the quickest option becomes available,
why don't we do that
that's
already?
Offered to the patient. Well, we don't do that. That's what I'm saying.
But why not?
Well,
I mean, it seems pretty straightforward.
It seems.
Is it the technology? Is it the computer systems that are not talking to each other?
It's partly because of that. Yeah, partly it's a data sharing issue, and partly it's a computer digital infrastructure issue. But these are fixable. We can't be sitting here in 2023 when I can order almost anything I want to eat within half an hour, and I can see when it's in the kitchen and when it's going to come into my door in a reasonable time frame. But actually, if I need a knee replacement, I don't know if the referral's been sent. It's only going to go to one particular provider, and it might be 3 years or 13 months. I don't really know. So
what does the government need to do to fix that?
Government needs to support local health leaders. It needs to ensure that they have the technology to be able to make these decisions. It needs to empower them, actually. Look, this is the patient pathway right now. Here's some freedom. Try and innovate it. Try and improve it so we can get through these lists quicker. That's what the local health leaders need.
Do I not remember there was some sort of computer system that was introduced, relatively recently, but it was just rubbish?
It wasn't relatively recently, but it's in the past decade or so. What we tried to do was implement a single top-down, centrally run digital system. It didn't work because it didn't think about the data ethics. The healthcare data is quite confidential. We have to be quite thoughtful between who collects it, how it's collected, how it's stored. And what went wrong there was that we sort of assumed that people wouldn't be too bothered. We didn't talk to patients about how do you feel about your data being collected by the state and who gets access to it. We didn't have those conversations. Those are conversations that need to happen, and they need to happen now, and then we can work out how to go about sharing data.
Another issue is the fact that there are 130,000 job vacancies in the NHS.
Yeah, and that's at the crux of this issue, really. The rate-limiting factor on increasing the amount of healthcare we can provide over a period of time is the amount of staff we have to be able to provide it. So that means two things. A, either bring more staff into the health service, or B, do more with staff you already have.
So how do we fix that?
So that's, well, there's industrial disputes going on, so that's probably...
I was going to come on to that.
OK.
But the 130,000 staff, does that mean that we need to relax the rules of people coming into the country, or can we feed those 130,000 jobs from people already here?
It's probably both. It depends on the job. Some of these jobs are incredibly highly specialised jobs. One of the most important workforce aspects of getting through specialist consultant-led treatment is the consultant. You can't just train a consultant overnight. That takes a long time. So we do have to look at how can we bring more consultants, incentivise them to come from other countries to come and work in the NHS. At the same time, we do need to train people more. We're getting back onto the 5 or 10 year thing. There's still 7 million people waiting today. And so part of that is about doing more with what we already have.
So do you agree with what the government was saying, what Jeremy Hunt said in the budget, that we should allow consultants to have a bigger pot as far as their pension is concerned?
So I agree with the problem diagnosis there. I think it's right for Jeremy Hunt to be thinking about, well, we've got a pension rule that incentivises senior doctors, senior nurses to retire earlier than they may have liked to because they're going to start getting taxed on their pension. The problem with that policy is that it's taking a sledgehammer to a nut. It's applied it across the entire economy for a problem that is relatively unique towards a particular public sector. Now, if you look at what happens for judges in the criminal justice system, they have a carve-out for their taxable pensions just applicable to judges. So a better policy may have been to try and do something like just for the NHS rather than apply that to the whole economy.
But there are a lot of public sector workers, it's not just doctors.
Right, it could be a whole public sector thing. The problem with the Hunt proposal is it applies to the private sector as well. And we'll lose a fair bit of tax revenue from bankers and hedge fund managers who now have a much bigger pension pot. That is not taxable.
Doctors on strike, junior doctors on strike. I'm guessing that you support that.
I am in support of that, yes.
Why?
For quite a simple reason. The job has become...
You want the waiting list to shorten, and yet you support doctors being on strike, and that probably will lengthen that queue.
Yeah, I think they're not actually opposing arguments. Let's say what's in patients' interest. What's in the interest of these 7 million people? It's two things, really. Sort a pay rise out and do it as quickly as possible. Sorting the pay rise out, why is that important for patients? Well, it's a big part of the recruitment and retention crisis. If we did pay doctors more, there'd be more doctors working in the NHS, there'd be fewer people going to Australia. That is good for patients. They would have access to care more in a more timely way. A pay rise is actually one of the best ways to improve care for patients. And why should we sort it out quickly? Well, that's for obvious reasons, to avoid disruptions that may come ahead of next week. We've still got this week. There's 4 days potentially next week where lots of these operations will be cancelled if we don't get to a pay resolution.
A quick thought before we let you go. We've overrun, but what would you say to the Health Secretary this morning?
I would say, whichever way you look at what's going on in the NHS, this feels like probably the most pressing concern in this country. I would tell him to get around his Prime Minister and other government ministers and think about what can we do over the next 18 months in the run-up to election to try and show real progress on the health service.
Thank you, Doctor. It's great to see you. Thanks a lot.